Detection, treatment, and prevention not only restore your quality of life, but can save lives. Gastroenterology at St. Peter's University Hospital, safely treating you better for life. This part of the program is brought to you by St. Peter's Healthcare System, treating you better for life.
Welcome back, listeners. You're listening to EBC Radio. This is 1170 AM. Our program is Heartbeat. Heartbeat airs on EBC Radio every second and fourth Saturday of the month. We're also live on the web, www.ebcmusic.com. I'm Dr. Dinesh Singal. I'm an interventional cardiologist. I'm the director of the catheterization laboratory at St. Peter's University Hospital and an attending cardiologist at Robert Wood and Princeton. I'm joined by my co-host, Dr. Meena Murthy. She's the chief of endocrinology at St. Peter's University Hospital and joins me every second and fourth Saturday to bring the show to you. Welcome, Meena.
Thank you, Dinesh. Today is a special day of collaboration between EBC, Dr. Singal, and our Indian counterparts. So thank you for arranging this, Dr. Singal.
So as you pointed out, we've been doing this show for almost 18 years, but today is unique in many respects. One, I think this is the largest panel of colleagues we'll have today on the show. Second, this is the first time in all these years we have a couple of esteemed colleagues from India live with us on the air. And finally, the one thing which may not work, we were trying to get a YouTube feed live, but I'm not sure if that's going to work today, but if it doesn't, we'll work the kinks out. COVID has taken over this whole globe, and as everybody knows, the situation in India is pretty bad. And I felt that the best way to get a sense of what was happening was to talk to people who were right in the thick and thin of it. And so to give us a sense of what the situation is, what the tribulations they're facing, and give us some not only practical advice to our listeners, but also for us to get a feel of folks who are sitting overseas, if there is any room for collaboration, because everybody's worried not only of their relatives and friends in India, but also how they can help. So we joined on the panel today, Dr. Ritu Aorora. Dr. Ritu Aorora is the Dean of Maulana Azad Medical College in New Delhi, India. And Dr. Mridul Daga, he's an intensivist, a director and professor in medicine at Maulana Azad Medical College in India, in New Delhi. So I welcome both of you and appreciate so much that you're taking the time this late evening to join us.
Thank you.
Me too. Thank you for calling us, and we'll be very happy to share our experience and our, all issues what we are facing in India today. Thank you. And to help us with this discussion, I have two of my colleagues locally in New Jersey, Dr. Balaji Yegneswaran. He is an intensivist and critical care specialist at St. Peter's University Hospital. And Dr. Kunjal Solanki, she is an infectious disease fellow at Robert Wood Johnson University Hospital and a very active member in API, which is the American Association of Physicians in India. So thank you to both of you to joining us.
Thank you.
Thank you, Dr.
Thank you.
So I'm going to get the session started by asking Dr. Aorora, in her administrative capacity, she is now in the middle of trying to get things organized at the hospital, at Maulana Azad and the hospitals associated. So if you can give us a sense of, what's going on the ground from your vantage point with COVID.
Yeah, thank you for having me here on the show. So to begin with, Maulana Azad Medical College has a hospital, Loknayak Hospital associated with that, and which is actually the biggest tele-hospital which is managing a whole lot of COVID patients at the moment. It's been for almost more than a year from March 2020 when we started. And till now, we've treated about 29,000 patients in the facility. Starting from March 2020 to 21, this figure was 17,000, which was admitted. But in last 2 months, this figure has been 12,000. So this much number of patients have been admitted in the hospital at different time period. And this is so-called the second wave of COVID. And currently we are dealing with far more sicker patients needing far more intensive care, and patients have higher mortality, difficult to get them back. That's the current scenario. So maybe I can tell Dr. Daga to further take on that with this background.
Yeah, I would like to add to what Dr. Ritu has said. We are getting patients large in number, and also especially young population in 30s and 40s. That's one thing we have noticed in this way. The other thing we have noticed is the clinical presentation has been quite different. We're now having people coming with high-grade fever lasting for 7 to 10 days. The fevers are the tune of, say, around 39 to 40 degrees Celsius, which was we not seeing in the earlier wave that frequently. We are also getting subjects getting sicker much earlier, Earlier we were seeing people getting hypoxia and other things happening on day 7, 8, 9, 10. Now we can see it even on day 5, 6. But that may be more because we are seeing too many or too large number of patients, and maybe their calculation of dates may be variable. But yes, we are seeing this kind of population, people without comorbidities, and some of them reporting very late with SpO2s of 20, 30 in the casualty. We have to straight away intubate within 20 minutes or so after giving them all possible things, or BiPAP or anything, because they are practically, obtunded, and we are losing them also. The other frightening thing which has happened is the spread in community is very fast, very rapid. Like when we were getting people from a household, out of the 4 or 5 or 6 members, 1 or 2 would get infected. Now what we are getting is that practically everyone in the household gets infected with no time. So the spread, probably there is more infectious, and the variants which we are having in the viruses, and B113.1. So that's a major issue which has led to this huge surge in cases.
Dr. Balaji, you want to talk to Dr. Daga a little bit about more of the differences in the presentation you saw here and what they're seeing there?
Daga, we also felt the same thing when we had the first wave last April, March, April. We learned in our thing that proning really played a big role, and that is what I have been recommending, that proning is something very, very good. And we try to delay ventilator as long as we can. I know family want ventilator. I have had a lot of family asking that doctors are not giving ventilators. And sometimes we tell them that not doing ventilator is probably the right thing to do. Do you agree, and how is the perception in your place?
Yeah, no, we are also practicing the same thing. Ventilator or invasive ventilator, or even that's the last resort here. I mean, we try and do our best with all these measures of proning, of putting them on high flow oxygen if required, or on NRM. A lot of people are doing good on NRM, and with 15 liters of NRM, a lot of people come out. It's not that. Ventilator, invasive at our center is also the last resort. And proning, yes, we do promote. A very small, minuscule number find it difficult, but we do motivate them to do that. And we tell them to do even for a short period, and then get into the side left lateral or right lateral, then go back to prone. So we are doing those measures, and we are able to avoid invasive ventilation quite a few number of patients. We also understand that.
Dr. Daga, most listeners are not doctors. What is NRM? Can you explain them what is?
And also, just somebody may not know proning, so if you can
Proning,
just
yes.
explain proning also, please.
Yes.
So non-rebreathing mask, so you have a connection, the ventilator, the oxygen you are giving is through a mask, through a bag in which there is a breathing going on, automatically, like someone has seen a closed wall or a closed balloon or something like that. So which is not the conventional kind of oxygen we give to the patients through a nasal prong or through a venturi mask. So that's what the non-rebreathing mask is. So, and that's been a great help. And in fact, I want to tell you that some of the hospitals in India are trying now using a Bain circuit. So putting the patients on Bain circuit, the circuit which we use for sometimes transporting patients on ventilator to get an MRI done or something. So it's almost on similar principle, and some people are doing well on that as well. So we are learning something new, and a hospital in the western part in Surat in Gujarat has recently done on 20 patients with that, and they've come out with very good results. So we are trying to avoid invasive ventilation, but that's the last resort. We're using all kind of means in, keep changing them from NRM to BiPAPs and again to NRMs and to high flow nasal cannula. And we are lucky that we are able to do that, but the new number is huge, and we have to really shunt the patients and shift the patients. What compounded our problem in last 2-3 weeks was this oxygen issue. That made us really very jittery, and that was completely unexpected. And so that was a mistake which, we at administrative levels, not at our level, but at other levels, we felt that we should have been proactive in, oxygen plans at the hospitals.
So we'll come to oxygen in 1 second, Dr. Daga. So Dr. Solanki and then Meena, and then I have a question for Dr. Aorora. Go ahead.
Yes, so I was actually going to ask a question on that topic itself. So with this increased requirements of oxygen, what is the status in terms of, where is oxygen needed, what kind of supplies are needed, and, where we currently stand going forward in this issue?
So maybe I'll let Dr. Aorora kind of weigh in first, and then Dr. Daga can.
See, oxygen supply definitely was pretty bad. It's just that our needs were not met with in the last 2-3 weeks. But currently the thing has improved. The more of oxygen has been shunted to Delhi. Initially, it was not coming, and overall, because of the increased need, it was less. Now, more places are putting up oxygen plants. And in Delhi, to an extent, I would say, the oxygen supply has been restored. And Kerala was, I would say, more proactive in that. They had stopped using the industrial oxygen earlier only, so that the oxygen supply could be maintained. So I would say, looking at Delhi status, oxygen situation is far better than what we were 2 to 3 weeks before.
So I think just wanted to add to what Dr. Ritu said is that the logistics of transporting the oxygen to Delhi was a big challenge. And no one thought about that, despite the fact that even in last April, decisions were taken at the central government level to put up these plans in 6 months. But unfortunately, those 162 plans were never materialized. And, in January and late December, Jan and February, everyone became little complacent, and things were not, taken in proper perspective. So that was a big challenge. And we in the hospital had that for 2-3 weeks, and we were, as fellows and residents and others, we were trying to, shift patients from one place to other, trying to reduce their oxygen who don't need it. So we have at any point of time, Dr. Singal, we have around 1,200 to 1,300 patients of COVID in our facility, largest in northern India. And managing those, and all those with moderate to severe disease, none with a mild disease. So it was a big challenge. And I must admit that, yes, we lost few because of this deficiency. We did lose, not to the large number, like what happened in some hospitals suddenly, that there was no oxygen. That never happened in our place.
That never happened.
That never happened, but it did happen that we had to, kind of suddenly found it pressures very low, the supply erratic, and 3-4 hours we were, thinking that now the supply is so low that we put patients on concentrators from oxygen cylinders or from NRM, but concentrators cannot give you that much. So we had to do all that kind of thing. But now we feel that we are improving and comfortable. And you must have all heard about what Mumbai did. Mumbai did fantastically well in that. And they used their resources, and they had a very good central command there, which regulated oxygen supply to the hospitals, needed hospital. And even with reduced oxygen, they could manage a lot of patients. So that wastage of oxygen and all that could be avoided. That was lacking in Delhi to begin with. Now it is improving.
Now it is. Now I see every day, all the measures how to conserve oxygen, even patients' usage. I mean, they have become very, very careful regarding that.
I mean,
You're listening to EBC Radio.
I would just add that it is not just India. Even when we had the first wave, the first week was very hard. Getting personnel, knowing how beds are, knowing how it is, meaning how to have mortuaries, and they suddenly increase in number of deaths occurred. And the learning process, meaning it is not, no matter, as physicians, it is like war. We don't know what to expect, when to expect, and what we are facing is something very different than what we are prepared for. And what we are going through is not in any particular book or textbook, or there is no plan. We don't do trial exercises for people coming in. It is just on the go, and a lot of people put in effort, and there are a lot of people who put their brains. They sit day and night and they work. And yes, we do make errors, and then but we are not defeated. We keep on trying to get solutions, and we make the next day better than the previous day. And that is what I want people to hear, that we are not that we are losing. Yes, we had challenges, but we can overcome. It is like, okay, we did less in one test, and next year we do better. That's how I look at it.
Just give me 1 second. So you're listening to EBC Radio. This is 11:70 a.m. We're having a panel discussion on COVID. The phone number in the studio, in case you have a question, want to join in, is 732-297-9886, 732-297-9886. I just want to give Meena a chance to kind of weigh in. Meena, Dr. Murthy.
Thank you. I wanted to make a couple of comments and, appeal to Dr. Daga and Dr. Aorora of, what we are asking. Time is short, so I'm just focusing on a couple of things. One is to, for our audience, I want to say India is a vast country. The needs of different areas of India and even different locations within the certain state, urban versus rural, are very different. So what we may be speaking about in particular areas, whether it's Delhi, Mumbai, and so on, may not be applicable to, some other smaller town or village. So the needs are very variable. We understand if our audience, certain areas, they have been affected by their own family members, or many physicians and nurses and so on are listening. So they have been affected in different ways in their own hometowns. So that's one to say. Two, it's a natural disaster, like any other natural disaster, whether it's tsunami or whether it is a earthquake. So no one can be prepared completely or perfectly, and preparation will vary according to places. And we learn from each other, we follow best practices. And Dr. Daga and Dr. Aorora, I'm sure, are extremely overwhelmed with the current needs there. So my question to them, so that we can focus on what our communities and our providers can do from here. In New Jersey state where we are, we have experienced this overwhelming problems, not to the extent you are, but definitely we have experienced it a lot. And we noticed, several things could help. And there are needs at the healthcare system level, there are needs at the provider nursing level, and there are needs at, social support and community support level. And here we have a huge community, not only in New Jersey, but across the states, and organizations who want to focus their efforts appropriately. And sometimes, the need versus the resource don't get connected well. So that's why I'm thinking of how you can, take some of this help to your community, whether it is, I know you need more nursing in your hospital, for example, but if that nursing isn't, available right away, can funds be, given to hire more nurses, or support the nurses who are already working? And can, telehealth, even if we can't help your acute patients, can we help their families, and can we help, their, because we found the biggest issue was communication with the families and the anxieties of families about their loved one being in intensive care. So, as physicians and nurses, we could help with that, and community organizations here could help with providing certain funds, certain resources. So I wanted to guide the conversation towards how we can help, how we can collaborate.
So I think before we get to that, I will tie this with this other question, which I'm going to present. Why don't we just get a feel of what the status of some of the limitations, and moreover, what is the morale of the both physicians and the other staff, and then what are the things which you feel need to be changed, and then we'll tie this into what Dr. Murthy is asking in terms of what are the practical ways in which we can make a dent. So if you can share Dr. Aurora first, and then Dr. Daga. Now I only have 2 minutes before the commercial break. We'll continue this piece of the conversation right after the commercial break.
Yeah. As far as the morale is concerned, it's not too great, because doctors have been working continuously for past 14 months on COVID. At least in our setup, nobody has had any vacation. Resident education has been affected. All the final year residents, even the undergraduate education has been affected. There's hardly any non-COVID work which was going on. So you're always doing COVID. And so definitely morale is not good. And we just keep pepping up each other, and you have to go on. There is nothing else which you can do at the moment. And you have to save lives. So at the moment, I tell everybody, forget about whether, I'm an ophthalmologist, and forget about that you're an ophthalmologist or you're, any other person. Just remember, you are here to save lives. So whatever anybody can do in his or her own capacity, please continue to do it. So here the leadership role comes very important, and how you can take everybody in that stride. And the next part is that how to carry over under those difficult circumstances. The circumstances in which the doctors are working in India, you can't compare them with the way you have the setups in US and other countries, So they're very, very challenging circumstances. And also you are dealing with so many number of patients, a deluge of patients, at the same time. So that, of course, in a way also helps, because you develop a clinical skill. You really develop a lot of clinical skill managing all those patients. And so that's how we are carrying on. And at times we do manage, as we said, there can be an oxygen problem. Just looking at it, whether the patient is mild, moderate, severe COVID, where we are going to put up that patient. So there may be a logistic problem. There is definitely a problem at the nursing care, because medical care is, I would look at it, 25 to 30% in the whole of patient management. Nursing care coming from even the nursing orderlies who help the patients completely back on their feet, that plays far more role in complete management. So there the community support comes out very, very important. So maybe Dr. Daga could add to that. I mean, that's the circumstances in which we are working, to trying to give our best, trying to have the least mortality which one can have, and deliver things. I mean, everybody's forgotten the specialty which you come from. The only aim is to continue to save the patients.
So we just went on a commercial break. So I'll let you know as soon as, and then we'll let Dr. Daga, and then we'll tie in with Dr. Murthy's question. Once we have kind of a sense of your needs, we'll get back to that question. So just give me 2 minutes.
This part of the program is brought to you by St. Peter's Healthcare System, treating you better for life.
You're listening to EBC Radio. This is 1170 AM. We're also live on the web, www.ebcmusic.com. We have a special show today. We're focused on the unfortunate situation in India with COVID. And we have an amazing panel of guests, both from India as well as local from New Jersey. We appreciate all of you who are listening. We hope you're finding this useful. I'm Dr. Dinesh Singal. I'm joined by my co-host, Dr. Meena Murthy. And we have on a Zoom link, Dr. Ritu Aorora. She is the Dean of Maulana Azad Medical College in New Delhi. Dr. Mridul Daga, who is an intensivist and director professor of medicine at Maulana Azad Medical College. Along with that, we have Dr. Balaji Yegneswaran. He's an intensivist at St. Peter's University Hospital. And Dr. Kunjal Solanki, she's an infectious disease fellow at Robert Wood Johnson University Hospital. The phone number in the studio is 732-297-9886, 732-297-9886. There was a question during the break, and before Dr. Daga kind of adds to what Dr. Aorora had mentioned before our commercial break, so both Dr. Daga and Dr. Balaji can, so the question was, the caller said that she heard in the news that there was a drug called deoxy-D-glucose, which may be helpful in this situation with COVID patients. So can Dr. Daga and then Dr. Balaji, please?
Yeah, I think ours was one of the center where this trial took place last year. One of my colleagues was involved in this study, which was a multi-center study. And this is basically when they looked into these patients with COVID and did FDG PET scan, and then they were finding that there's a lot of deposition there in the lungs and all that. So this deoxy-D-glucose is just to prevent that deposition and proliferation of viruses. So this is simply a glucose molecule modified, which can be given. So this is a good thing. It is not really a real drug in that sense, but yes. So this is, I think, been approved just yesterday by the drug controller in India here. And hopefully, let's see, how early we can get it. So it's a approval, very fast track approval for this, and a harmless molecule for that sense, and should be able to, prevent that viral replication and deposition in lungs, and where there is a lot of deposition of these, which was seen in studies.
Dr. Yegneswaran?
So I would say that, yes, it is nice to hear new drug. If you say in the past 14 months, we have had so many new drugs approved through EUAs. Many drugs come with a great hope and then they fizzle out. Some remain. And so therefore, basically, there's a hope is there. People are working day and night. Dr. Daga said people are doing multiple trials. Many molecules are being tried. And I hope that good results come. And protocols are being formed and based on how they did, and they're trying to add it. And hopefully it will lead to good outcomes. All we are trying is to reduce the mortality rate, which is climbing very fast. And so we'll wait and we'll see with more results coming.
And this is also good news because, currently India is also lacking therapeutics such as remdesivir, tocilizumab in many areas. So having a molecule drug such as 2-deoxyglucose can help fight COVID in those areas as well.
So I just have another caller on the air. Let me just listen to the question and then I'll narrate it to you. Hi, you're on the air on Heartbeat. Hello, you're on the air on Heartbeat. Hello, can you hear me? Can you hear me? Okay, so what's your question? You're on the air. So I'm sorry, it's a CT scan score you're saying? So let me just, because I have everybody on a Zoom link, they can't hear you. So let me just repeat the question to them. So this is to the pulmonary intensivists. The caller is saying that there's some relative of his in India whose CT scan score has gone from 6 to 22. And so one is how critical that is, and two, whether these repeat CAT scans have a deleterious effect. Is that the other part? This is for the caller. You say the second part of your question was what? Okay. Okay. So there's two questions. One, the score went from 6 to 22, and is there a downside to repeat CAT scans? Dr. Daga?
Yes, going from 6 to 22 is definitely a severity of the disease has increased. But if he's in the right hands, it is getting proper treatment, I'm very sure. We just want to know that he is still not on an invasive ventilator. And so the treatment would help him or her, whoever the patient is. But yes, one has to be on watch. What is the oxygen requirement? What is happening to that? And how is he maintaining his saturations, So yes, the disease is severe, but there was no need for doing a CT earlier, which the score was 6. So this is too much of a CT scan going on, which was not really needed. So exposures do happen with CT scan. Yeah, the radiation with now new modern machines are much lesser, but they are much, much more than a simple X-ray test. So I would advise that no CT scans until unless really indicated, or you are not left with any other investigation to treat or further proceed in the case. So that's what my suggestion would be. CT scans are not really treatment.
Dr. Balaji, you agree? Keep it short because we have a few.
I agree with Dr. Daga. In US, we don't have resources so much to just do CT on everybody. I know in Asia, people do a lot of CT scans. We don't do. And yes, any radiation leads to some side effect. Yes, it is less with modern thing, but we have to try to avoid CT scans if we can.
So thank you for your. So the caller, I hope then. Thank you for your call. So I think we're going to run a little shorter time. So I now want to go to the question which Dr. Murthy had raised about the resources which you think can add, since Dr. Solanki is involved with API and she has some thoughts, I'm going to tie this together. So Dr. Daga, from your vantage point, do you feel, there's a large Indian community and even non-Indian community which is trying to figure out ways to help India. So since you're on the ground, what are some of the ways you think there can be help? Dr. Aurora and then Dr. Solanki can weigh in. Go ahead.
I think the real challenge we are facing is definitely some fatigue setting in the healthcare workers. How do we augment that? Or how do we support that? That's the thing, like through a telemedicine or, having setups in units, in wards, in ICUs, complete setups with, your Google have, Google Hangouts or something like that, where communication becomes easier between patients and their relatives, between patients and even doctors. No one has to repeat same things again and again. That's one of the biggest challenges we are still facing. We have done a lot of those things in our hospital. We have constant video chatting facility for patients attendants to talk to the patients at least once or twice a day. But again, that number is so huge that sometimes the system, so we do lack in that. That's one thing where a lot of help can come in. I'm very sure Dr. Ritu would agree that we can suddenly seek, because this being a government setup, sometimes these issues come up, how you're taking help without permission from the government, but I'm very sure we'll be able to overcome that. So that is one thing we are facing. And I'm also really at loss to understand, India being the hub, IT hub of the world, we are still not able to develop a foolproof system of proper awareness amongst people who are rushing from one hospital to other hospital to get a bed, not knowing that the beds are available there or not there. And they are dying at the doorstep of the hospital casualty. So something, that kind of a thing. So we did try that IT link of every facility in the city should be made. And if that IT link is so efficient that it gives a real-time scenario what is happening, because you don't have people. So we need some IT support in our hospital also. Some people volunteering and working there in shifts, 8-hourly shifts are also, the feeding all those data, doing all that work so that this information goes on a central portal and it helps. So this system is still not developed fully. And in a city like Delhi, this is a big challenge. So this is one support I think would help a lot in cutting the misery and, a lot of suffering patients and their relatives have in terms of that. As far as home care is concerned, yes, a lot of physicians are doing that through the video chat and other WhatsApp and all that, are able to manage a lot of patients at home. And my personal experience have been that probably in last 4 weeks, I must have managed almost more than 100 patients of moderate disease or even moderate to severe at home. Because I thought that don't go for the hospital, no beds, just do not bother. But we have been able to arrange giving them drugs, even oxygen at home to some patients, and some people were able to get that. But again, this is a big challenge. So my main take is that, yes, augmentation of support staff, community support, even patients in the hospital, because of, paucity of, less number of workers in terms of, transporting them, giving them daily support of wash and toilets and all those things, and even meeting their other requirements. So in that level also, we need some community support. But the biggest we require is this IT linkage so foolproof that this kind of thing doesn't happen.
Before I have Dr. Solanki step in, I have another question which just got texted to me. Role of ivermectin. Is it ivermectin? Dr. Balaji, you want to step in, and then maybe Dr. Daga or Dr.
So that is meaning it is not. In India, people use it.
So what is ivermectin?
Greatly.
What is ivermectin?
So ivermectin is actually the drug used for river blindness. A lot of it is used for, suppose you have scabies and you got a lot of drugs you can use it for. So the idea being that, hey, can it be used for COVID? The theory is that it prevents multiplication, but FDA has shown the dose at which it does is like 100,000 times the dose what we normally give. And therefore it was FDA had said not to use it. Having said that, people do use it because they say there is no harm, and that is the attitude that has been going, that why don't we give it with no harm. I in my practice have never used ivermectin for COVID, and I don't recommend it to anybody to use ivermectin.
But I've seen in India they use it. It's similar in a same concept as hydroxychloroquine, because it's widely available, because it's cheap, there is no side effects. It's part of the cocktail.
No, there's no drug which doesn't have side effects. So let's put that. That's just right.
I fully endorse what Dr. Balaji says, but it's being used left, right, and center in India. And in fact, a lot of guidelines from premier institutes, including All India Institute of Medical Sciences, they have advocated this use for a few days, not of very high dose, unfortunately. And just last week, there is a huge meta-analysis published of around 15 RCTs and 20 just other trials combining all those. And it has shown some benefit in terms of, disease duration being reduced to some extent. But again, there are no definite hardcore evidence, but it is still being used. I know that. I, in my practice, generally do not recommend it to most of the time. Sometimes I recommend it out of some peer pressures, but generally I also do not advocate using it for.
And even with the AIMS guideline on ivermectin, they do put 2 stars over it. I mean, AIMS alumni, I will say that they also don't recommend it. They do put 2 stars because there were a lot of peer pressure. So, but they too don't recommend ivermectin.
So going back to, we have about 10 minutes left. So Dr. Solanki, I know you've been active in RP. There have been a lot of initiatives. So if you can share some of the ideas which you have and see if we can reconcile with what the needs are on the ground. And the second thing I just wanted to say, this idea of IT help, I mean, we probably have a lot of IT people listening here, and that sounds like something which should be, with situation as bad as it is in India, that people can step in and help out. But Dr. Solanki.
Yes. So thank you, Dr. Singal, for coordinating this again. This is a big platform and an opportunity for us physicians in US to be able to help out our colleagues in India. So I just wanted to briefly talk about API. API is an Association of American Indian Physicians of Indian Origin in US, which is the second largest physician association after American Medical Association. So just like API, there's other physician associations in US as well who are stepping in to help during this time. Currently, our efforts are focused on generating funds to send oxygen concentrators because, as you know, the media has that's the aspect of the pandemic that the media has hyped. So everybody's really affected by what we have seen, the situation in India currently in the Indian hospitals. So during the current situations, we're focused on sending oxygen concentrators, but we're also gathering money to send supplies such as pulse oximeters, face masks, anything that is required in India. As it was mentioned by Dr. Murthy before, that Delhi and certain cities situation might be better currently, but there's still villages and places with lower poverty and poor lower socioeconomic status that may require these items right now, because we're still in the middle of the second phase currently. So we are working to send these supplies. In addition to that, API is also involved in advocacy. So our team will be meeting with all the US representatives at the Washington, DC and the Capitol. And also we are coordinating with the Indian Health Ministry as well to better come up with rules and regulations for this telehealth platform. So telehealth platform is something that we are working towards. So this is where the IT part comes into place, because there are already existing established telehealth platforms in US, and we just have to coordinate with the Indian ministry to make sure that all the malpractice insurance and the liability, the legal issues are sorted out, and we will be able to provide telehealth help from US and from around the world to Indian physicians to take off the burden from their shoulders at this time. So, with all, so it's very important for us to know exactly where the needs are at this time, because right now everyone is in the chaotic situation. People are transporting the concentrators, they're going in the major cities, but then we really need help from the Indian side as well to help relocate these supplies to the needy areas. So I think
since we're short of time, therefore I'm intervening right now.
Sure.
Yeah. So if you really have to divide, your whole support system, as Dr. Daga said, of course, one is the IT part. Second is as per the logistics part. So in logistics, you may have oxygen concentrators, oxygen cylinders, or maybe say BiPAPs. So oxygen concentrators, as far as we've seen, if you send a 5 liter, there's so much of donation coming right now of 5 liter oxygen concentrators. For the current system, since we are getting moderate to severe COVID, so the utility of this, I find, is very less. If at all, the 5 liter concentrator may work only for, like milder patients who need some bit of home support. If at all it's needed, you can send 10 liters. So which can go to the periphery and smaller towns, which may be of, some help, not so much of help, but some help. And then sending BiPAPs, good quality BiPAPs and good quality masks would be of great help. Maybe Dr. Daga can correct me in that part.
And
so
what
that,
about ventilators? Yeah,
that is the logistics. And more, I personally feel, is the manpower. Manpower needs, somehow we have to see how it can be worked out. Support in the form of manpower, and as far as nursing is there, as far as the other paramedical support, even technicians, So we may have a good BiPAP, I may have a good ventilator system, but if suppose we don't have a good technician help, it's as bad, So having a manpower, that's the third part. And the fourth part is building up, and I'm very concerned about it, building up the morale of the healthcare workers in whatever way which can be done. Again, the logistics has to be worked out. So if Dr. Daga could add to it, that would be next part.
No, I think you summed it beautifully. I think that's all what we need. We need what you said. BiPAP to some extent. As far as the gadgets are concerned, not more anything in instruments or gadgets much really, but yes, in interior towns and all that, you may need even oxygen concentrators sometimes, or oximeters and things like that can all be there. BiPAP with good mask. And again, this other thing is about the support staff deficiency we have. And lastly, but not least, the way to keep the morale high. We are doing our best. Dr. Ritu is doing her best, being the dean of the institution. But yes, some kind of.
I wanted to add, while organizations like API are working at a very high level to bring greater level of resources and coordination together, there are many provider-led organizations who are willing, not worried about the malpractice and so on, but willing to do simple humanitarian support. For example, Dr. Daga, you said you were spending hundreds of hours counseling patients on telehealth or their families. If some of that load can be taken away from you, from me or Dr. Balaji or people like that, then you could focus on your very sick patients who are actually in intensive care. So that's the kind of real support we are thinking about. And for that kind of support, we don't have to worry about malpractice and insurance and all of that. We are just, there are thousands and thousands of even women physicians, nurses, physicians who are willing and can be guided by you to support the people so that you can all be relieved. Here, one group of orthopedic residents just went ahead and just pruned the patient and took on the care of the nursing because their OR was closed. So anything like that. So like Dr. Aurora said, we don't have to worry about our specialties. We just want to take any part in saving those lives, whatever that may be. And so when bigger organizations are working on, more concrete support, there are many smaller organizations which can provide to one hospital or one area, one region, and we can group ourselves to connect with you like that.
So we have like 60 seconds left. So I think Dr. Daga, just one before, because we might get cut off on the air. I want to thank everybody. This was amazing. I'm already getting text messages to continue past 1, which I know we can't. So I would like to extend another request and invite. If we could, I'll be in touch after the show. Maybe we can have this again, because I think this is extremely useful, and hopefully we can get not only the listeners who are on the air now, I'm pretty sure that they enjoyed and actually found this useful. So I want to thank Dr. Ritu Aorora. She's the Dean of Maulana Azad Medical College in New Delhi, for joining us. Dr. Mridul Daga, he's an intensivist, director, professor of medicine at Maulana Azad. Dr. Balaji Yegneswaran, and Dr. Kunjal Solanki, who's an infectious disease specialist, and Dr. Murthy, who's my co-host. So with that, Dr. Daga, you have, actually I don't have much time, so I thank you again.
Okay,
thank you for joining. I thank all the listeners, and we'll be back with another edition of this program.
Thank you.
Thank you very much. Thank you.
Thank you.